Yeah, good afternoon, everyone. My name is Victor Rao, and I'm going to be talking about the lower extremity venous ultrasound for DVT assessment. Of course, we're going to be discussing just the 2-point, also known as the 2-zone compression test, and it's not going to be the full test that we do in radiology. The agenda for today, very briefly discuss the anatomy that's going to be reviewed, as well as how to perform the scan, and also just to keep in mind, just to remind you again, this is a very easy ultrasound exam to be performed and is known as a venous compression test, and is done using B mode ultrasound, the black and white images that we are familiar with, and also some adjunctive modes like color Doppler and spectral Doppler when indicated. And of course, what the DVT would appear on ultrasound, and some limitations and pitfalls, and also be aware of, make you aware of the Mayturner syndrome. Just some couple of notable facts. I won't go through all of them, but just to kind of keep in mind, this is a preventable cause of death, and also since 1982 was when the first case of DVT was reported. And I checked the CDC, and they give a very wide range of 300 to 900,000 patients being affected annually. But they also claim that nobody really knows how many people are actually affected. But ultrasound, just to be aware, is a very sensitive method of diagnosing deep vein thrombosis in the lower extremity, and also very specific. And also the cool thing is that it's very easy to learn. A few things to be aware of, reminded ourselves as the virtuous triad, or those things like stasis, trauma, patients with old contraceptive, obesity, and hypercoagulable conditions may predispose the patient to develop thrombosis. Also be aware that pain, swelling, redness is seen in the affected region, the affected limb, but it could also be asymptomatic. We have seen patients who have redness and swelling on the left side, but they actually have a deep vein thrombosis on the opposite side. So that is very much possible. Only 5% of the calf vein thrombosis will actually cause symptomatic deep vein thrombosis. And also 30% of the calf DVTs will actually extend to the popliteal vein region and higher. And that's one of the reasons why we want to do a follow-up exam after 1 week, because we have not assessed the popliteal region when we're doing this particular examination that we're calling as the 2-zone or the 2-point compression test. Very briefly about the anatomy, as you can see here, you can see this is a deep vein right here. This is the external iliac, and as it crosses the inguinal ligament, it actually becomes the common femoral vein. And also one thing to be notable about the deep veins is that they also have an adjoining artery with them. That's the difference between a superficial vein versus a deep vein. Not just that they are deeper, but they also have an adjoining artery with them. Just that was a little bit complicated diagram. I have a very simple diagram that I drew. We can see here this is the inguinal ligament, and of course this is above the inguinal ligament, we call it external iliac vein, and below the ligament we're going to call it the common femoral. Here we have a long saphenous, also known as the greater saphenous vein, coming and joining over here, and this is the saphenofemoral junction, and it goes further down and then divides into the superficial femoral and the deep femoral vein. The deep femoral vein is only seen for a certain short segment. And now the superficial femoral vein is actually a misnomer, and they have changed the terminology. They call it only the femoral vein now, because a lot of people were accidentally not treating a thrombosis present here because the report said superficial femoral vein. So they have gotten rid of this superficial, and now they call it only the femoral vein. But you might come across a report which called the superficial femoral vein thrombosis seen. So keep in mind that is actually a part of the deep vein system. It passes along the medial asphalt thigh, goes posteriorly through the adductor canal, and in the popliteal region posteriorly, you will actually see the popliteal vein. And of course, further divides into the anterior tibial, we have the tibial prone trunk. But for the purpose of this exam, the 2-point or 2-zone compression, we are only looking in the highlighted area, and we are not analyzing the rest of this. And there could be also variation in anatomy. As you can see, the vessels could be duplicated and the origin or the divisions might occur at different levels. So those are things to be kind of kept in mind. If you do see duplication, then make sure that you do assess the duplicate vessel also. The transducer of choice for this per exam is going to be a high frequency linear transducer. As you can see, this is a high frequency transducer with a straight edge right here. And this is the I would give it 5 stars for it. We have a curvilinear transducer, which is not recommended, but sometimes you may have to use this one simply because the patient actually happens to have a vein that is very deep inside the body. They could be swelling or they could be obesity. And so for that reason, because this has a shortcoming that it can't look beyond 5 centimeters. We also have the new butterfly device, as you can see over here, that is very much capable of performing the exam as well. So here we are going to review the anatomy on the ultrasound. Here you can see this is just below the inguinal ligament, and before the point of bifurcation or before the point where the long saphenous or the greater saphenous is going to meet it, and we have the right common femoral vein and the right common femoral artery on this side. Probe marker is pointing to the patient's right side. And we have this relationship to remember, VAN, vein being the most medial, and then we have the artery and then the nerve in the femoral region. We come to the saphenofemoral region, we have this something known as the Mickey Mouse sign. We will see the, and of course next to that we'll have the common femoral artery. Go further down, you see this artery divide into 2, and then the vein also is going to divide into 2 as well. Before that, it actually goes a little bit more posteriorly to the artery. So we call it the Mickey Mouse sign, or known as the saphenofemoral junction. Here we have the common femoral vein, and we have the great distance color Doppler view. You can see there's a little valve present over here. And this greater saphenous, or the long saphenous, is actually a superficial vein. But we do want to analyze this area simply because if there's a clot present over there, as you know, blood clots will grow in size, and so they will cross over. And I see lots of patients with these clots extending and traveling in this area and becoming a deep vein thrombosis. And that's also the reason why we like to treat patients within these 2 centimeters of this junction. If there's a clot is present here, we want to definitely treat it like a DVT with anticoagulation. This is the popliteal region. You can see that this is a long axis view showing you the anatomical relationship. We are assessing from the popliteal crease region. And you have this is the skin, subcutaneous tissue, the muscle. And of course, this is the popliteal artery, and this is the popliteal vein. And this is the transverse view. In transverse, we can see artery here, and the superficial one is going to be the popliteal vein. The test is really very simple. You just find the vessel in question, the deep vein, make sure they have the artery next to it, so we know that is a deep vein. And then we simply compress down in the transverse view, and we have to obliterate the vessel. We have to call it coaptation. And the vessel should completely collapse. If not, then you're not either putting enough pressure or there's a clot present in it. Sometimes you may actually see the clot present also inside the vessel. But at times you may not even see the clot. There could be a lot of artifact in the area, which will make it difficult to determine that. But essentially, this would be a norm finding when it totally collapses, anterior and posterior wall while touching each other. You can do counter and also when you're doing the scan of the popliteal region, you want to put pressure, counter pressure on the, on the kneecap, just to kind of make sure that you're not causing the patient too much discomfort. Here's a view. You can see patient's leg lying supine. We have to the scan within the reversed Trendelenburg position. I've noticed lots of times we're not able to see, especially the greater saphenous. So if you elevate the patient's head end about 30 degrees, that's actually going to fill up the vessel and going to make your job easy. Make sure you're not putting too much pressure with your hand or the probe, because these are small vessels and they have low pressure, so they may collapse. So you want to kind of, I would say that almost imagine that you're like a butterfly, and you're putting the pressure on the patient's skin surface, and then you identify the vessel, bring the venous in the middle of the screen, and then go ahead and compress. Here's another view kind of showing you external rotated and kind of flex of the knee over here. I'm going to show a video so you can kind of get an idea. So we're putting pressure, and you can see the vein is completely collapsed, and so there was no thrombus present. And essentially, you want to move 1 centimeter below and do the exact same thing. So we have here, this is a normal compression, and we like to document it on the image. We like to also capture a video for that. But this is where you can split the screen up, and on the one image, you can actually see on this end, we have the without compression and the with compression at the same level. And here it is, you can see the test being performed, the popliteal region, with the transducer there, and then we can even have the patient sitting on the edge of the bed. At times you have difficulty, we can even have the patient stand on the floor to kind of distend the popliteal veins so they become more prominent. Here's another video kind of showing you what you would expect in the normal conditions in the popliteal region. Here you see the popliteal vein, and this is the artery, and clearly it's fully compressible. So the test, as you can see, is very, very simple. There's nothing complicated about it. If so, how would you diagnose it? It's either you see the clot, if it's present, but that's not very reliable at times because it could be artifact too. The most reliable thing is with the compressibility. So non-compression or partially compressible deep vein. Make sure you're putting adequate pressure. And if that is, and of course, other things like color flow that could be done, but they're not very reliable or that sensitive, but they could be adjunctive. So also you find that at the same level, on the opposite side, we see a normal distension of the vessel. The affected side of the clot may have a large clot in there, and the vessel diameter is much more as compared to the opposite side. So that would also kind of indirectly and indicate that there could be a thrombus present, but keep in mind the gold standard for when you're doing ultrasound is going to be the compressibility test. In the B mode, we do not want to do the compression in the long axis. We do not want to do the compression using color Doppler. It should be just black and white. And also when you do see a clot, sometimes you see the clot is kind of moving freely in the bloodstream. You should not be compressing too much or not trying to bring your residents or students say, come on, 20 students come over, let's scan this patient and check it out. That could actually cause the clot to break off and cause a PE. And of course, here is that what we was telling you earlier. This is actually a greater saphenous vein. You see a clot, echogenic clot present. It's going all the way from there, and it's actually extending now into the common femoral. And so this obviously needs to be anticoagulated. Here another example. You see a clot is present, and this is without compression. This is the with compression image, and clearly it's not compressible completely. Over here, I've just showed you the same image. As you can see, it's hard to tell what is going on, but of course non-compressible. We would have seen the clot better if we had the proper gain setting. So make sure your gain is not set too low, so you can increase the gain to make sure the clot and everything else is visible. So one question, this is one patient saw that, somebody was wondering, is that a clot in there? I have a video for this, so I'm going to play that. Keep in mind that sometimes the blood in the vessel, especially when the patient is not, it's not lying supine, or could be standing, or could be sitting on the edge of the bed. So the blood can actually look white and echogenic, but this one obviously is clearly the blood is. And you can do a compression test, and of course, the compression test will be negative. Another thing that I would like to talk about is doing Doppler. Spectral Doppler is very helpful when you're trying to assess a vessel, because normally you should have this normal phasic flow present, and if not, that would indicate that the patient perhaps has some obstruction, could be extrinsic, could be intrinsic, could be a blood clot, could be even a tumor, or even a large fetus lying on the IVC or iliac vessels, which could be causing that. So this is known as the monophasic or the non-phasic flow. You can see how different that is. I'm going to go back to the previous one. So you see there's a variability with respiration. So make sure you ask your patient to take a deep breath in and out. And if that is present, that means there's no obstruction, no clot present from the site where you are examining all the way to the right atrium. So that's a very powerful statement right there. If you see this, then definitely there's something wrong. And you'll be surprised. At times, I've heard some experts talking that the only thing that they saw positive in the patient was a monophasic waveform or the non-phasic waveform. Everything else checked out normal. So perhaps the patient had some clot present in the iliac vessels or even in the IVC. So what is the significance of the monophasic waveform? It definitely suggests something is not right. There's some obstruction to the vein, to the flow of blood in the vein and the deep vein. And it could be intrinsic, could be extrinsic. As I mentioned earlier, mass or even advanced pregnancy or twins, triplets could cause that. So be aware that it doesn't always mean there's a thrombus. If you have a monophasic ipsilateral waveform, that indicates a more proximal disease in the iliac vessel. That means only the iliac, because if it's bilateral, then either we have a bilateral iliac vein involvement or we have something like a large clot sitting in the patient's IVC. Also be aware that the patient has had DVT in the past. It could cause the flow to become monophasic. Here's a treatment chart you can see for actually diagnosing DVT as an algorithm. So pre-test probability for DVT is low, do a D-dimer. If it's negative, obviously DVT is excluded. You do a D-dimer is positive, then do the two-zone, two-point compression test. And if it's negative, then obviously we want to do a follow-up after 1 week. Reason being that because we are not looking at the entire vascular tree, we're not looking at the vessels in the calf, even the mid-thigh. So the clot, if it's in the thigh, would extend up, grow larger in size and be visible at the level of the the popliteal vein. If it is positive, obviously, then we start anticoagulation. If the probability is moderate to high, then we do two-zone compression. And if it's negative, then obtain D-dimer. Is negative, then excluded. If it's positive, then we're obviously going to anticoagulate. So D-dimer is positive in this situation here. We can see that we would definitely want to do a full study and also do a follow-up if possible. The full study, in my opinion, should be done in patients, even if you're doing a two-zone, two-point compression test, because we're not really looking at the entire vessel tree, and we couldn't possibly do that because that exam would take 45 minutes. So compared to this one, it would take about 5 minutes to do this. So other things to be aware of when you're doing this is to make sure that you don't know what the appearance of a lymph node looks like. I kind of describe like a baby kidney. Here's something that you might encounter in the popliteal region. So this is a Baker's cyst. As you can see, it's communicating with this space of the joint space right here, the knee joint. And you can use color Doppler and it will be no flow in there. So a couple of things to keep in mind here. Main thing is that you could consider a non-compressible vein to be a DVT, didn't put enough pressure, or you mistook an artery for a vein, or you mistook the lymph node. That's why it's important to know what lymph nodes look like. And also, a negative study does not rule out the possibility of DVT and P, because still could be there. One condition that we should know, especially when dealing with DVT in lower extremity, is Mayturner syndrome, described by May and Turner in 1956. I was surprised to know that 20% of the population have this, but not everybody is going to be symptomatic, and therefore, for that reason, we only treat when the patient is going to be symptomatic or recurrent DVT. And here it is. It's just an anatomical variation. You see what is happening here is that the patient's right common iliac artery is crossing anterior to the left common iliac vein as it crosses over. Ideally, this vein should be in front, but 20% of the population has this vein going posteriorly. As a result of that, you can see here it's compressed against the spine and the artery in the front. And you may have a patient walk in, and that's what she looks like. You see there's obvious left-sided swelling, and increase in girth, as can in this patient as well. So if it's the left side being affected and if it's recurrent DVT, you should be considering the possibility of Mayturner, because you could end up putting a stent in here to prevent something happening like that again. The final thoughts are the patient should be put in a reverse Trendelenburg position, head and up 15 to 30 degrees. This test the two-zone compression does not rule out the possibility of deep veins. But we have looked at the hot spots where the highest probability and the ones that cause havoc are there. Combined with the spectral Doppler, it's actually going to be a very powerful, effective tool. Here's one video that I'm just going to share with you. Obviously, so IVC here, and you can see the right atrium over here. To kind of get an idea that I think you should also look at the IVC and the right atrium if you are assessing the patient, because look at this. Nothing was found in the lower extremity, but if you can see over here, does this patient have a DVT? Yes, the patient does have a DVT. In fact, it has already embolized, and this is the clot is bouncing back and forth from right atrium to the IVC.